Today's talk will be on several subtopics. Already I discussed about things. The first we'll start with diabetes and surgery. Okay. To learn about the perioperative management of a patient with the diabetes undergoing surgery, either major or the minor, how to manage critical and non-critical ill patients with the diabetes in the hospital. So you often see the people in the ICU, in the wards and in the rooms. So how to manage the hyperglycemia very effectively, not to have any complications. How to identify, evaluate and treat the sexual dysfunction in a patient with the diabetes. So this is also very, very common in the society. Erectile dysfunction, it's a secret symptom. So one has to be identify and how to evaluate and how to treat these things. How to manage the diabetes in an elderly patient. So now the elderly people are increasing in the numbers in a tsunami proportion in India. So right now we are having nearly 20 to 25% of Indians are elderly. So lot of the drugs has to be managed according to his renal output, according to his cardiac function, according to his brain function. So we have to reduce the dosages or we have to change over to the insulin in some instances. And we have to treat the comorbidities also in all elderly population because so age is a important risk factor to have the hypertension. So more than 80 years of the age group, I think 85 to 90% are hypertensives. If not the diastolic hypertension, at least the systolic hypertension. So all these people, they require either a low dose diuretic or a calcium channel blocker. And most of these people, especially in the diabetics, in the elderly population, that means they are living with the diabetes for more than 20 years or 30 years or 40 years. So obviously, they must have had some ischemic heart disease or some chronic kidney disease and etc. So all the drugs, multi-drugs or polypharmacy is a very rule in elderly diabetic individual. So it is very difficult to manage the diabetes in comorbidities in elderly individuals. Let us discuss about it. What is the syndrome of the non-alcoholic fatty liver disease and its management? Now the fatty liver disease is a very common ultrasound report. Whenever you send for the ultrasound abdomen for whatever may be the symptom, finally the report is fatty liver grade 1 or grade 2 or grade 3 etc. So this fatty liver is also included as the fifth parameter of your metabolic syndrome. I discussed that the metabolic syndrome is a cluster of diabetes, hypertension, dyslipidemia, obesity. Now we have to add the fifth point as the fatty liver is also a part and parcel of the metabolic syndrome. That means that whenever you see a case of the fatty liver, you have to check for the other four parameters of your metabolic syndrome. Then what about the common dental and the rheumatological problems in patients with the diabetes? So now the dental problems are very common, especially in the chronic diabetics and also in the elderly population. So the dental problems will give a room for the lot of the bacteria to reside in these cavities or caries, teeth, etc. And these could be one of the important risk factor for the early ischemic heart disease. Now the dental and ischemic heart disease is a big relation, a bidirectional relation. In the same way, the rheumatological problems, you all must have seen a lot of the people with periarthritis of the shoulder, frozen shoulder, so the trigger finger, Dupuytren's contractures. So these are all the rheumatological problems, very common with the diabetes. On the other hand, diabetes people are, especially the female diabetics, might have had an associated rheumatoid arthritis or ankylosing spondylitis or the lupus or systemic sclerosis or mixed connective tissue disorders. So the diabetes and rheumatology is a very, very big entity, and let us discuss about it. Then how to manage other special situations in diabetes like travel. So now the lot of the people are moving from here to the east or the west. So how to manage their insulin dosages, etc. And of course, during the sick days. So what about your medical management about the diabetes and what are all the occupational problems? I think this topic is a very, very important practical point we often see day in and day out in our clinical practice. So let us concentrate on the surgery and the diabetes. So the diabetics people experience higher number of the hospitalizations. You all know that because of the hyperglycemia, they invite a lot of the infections. And surgery with a longer hospital stays So a non-diabetic and a diabetic, usually the diabetic will stay in the hospital for the longer periods. So before the surgery and after the surgery also, for the proper control of the diabetes before the surgery and after the surgery if they develop some wound infections, etc. And obviously the higher treatment cost because they are residing in the hospital for a longer period and you need to use the higher antibiotics. So definitely the cost will be high. And sometimes these people has to be kept in the ICUs for 1 or 2 days post surgically. So definitely the treatment cost will be high in the diabetic individuals. And why we are giving a lot of the respect to the diabetes in surgery? Because to reduce the morbidity and the mortality, because the diabetics will have a lot of the morbidity and the mortality intraoperatively. Major surgeries are defined as the procedures requiring general or spinal or epidural anesthesia. So whenever a surgery will be done under general or spinal or epidural, so it should be considered as a major surgery, but I'm not giving much importance to lasting more than 1 hour. See, some surgeries may last maybe 30 minutes or 40, depends on this hour depends on the speed of the surgeon. So I don't give credit to the duration of the surgery, but I definitely give the credit if the surgery is done under the general or the spinal or the epidural. And if the hospitalization is more than the 1 day, even now the daycare surgeries are performed, even they are also the major surgeries. So I don't give much importance to the hours of the surgery or the days of the hospitalization. But what is more important for a major surgery is when the surgery is done under the spinal or epidural or the general anesthesia. And all other procedures are defined as a minor surgeries like the tooth extraction or cataract surgeries and etc. Metabolic responses to the surgery and the effects of the diabetes. Why we are giving a lot of importance to the diabetes during the surgery? Surgery itself is a big stressful condition, and trauma you produce during the surgery is again causes the more stress. And if you develop the wound infection, again the more stressful condition to the patient and of course to the doctor also. And hemorrhage is always common in any surgeries. So definitely that depends on the amount of the hemorrhage, and definitely that also becomes a stressful condition. So stress because of the surgery itself or because of the wound infection or because of the trauma and the hemorrhage, these people will be under more stress and strain. So this stress causes increased sympathetic activity on one hand and increased counter-regulatory hormones on the other hand. Suppose if you see the increased sympathetic activity, so obviously because of this increased sympathetic activity, insulin secretion will be inhibited. So obviously once there is a less insulin secretion, the glucose levels will be very high. On the other hand, when the patient is having the more increased counter-regulatory hormones like your steroids or your growth hormone or your epinephrine, norepinephrine, etc., so the insulin sensitivity will be reduced because of this counter-regulatory hormones. Again, that also will cause more and more hyperglycemia. So this hyperglycemia is because of the glycogenolysis. So what are all the stored glucose there in the liver in the form of the glycogen that will be converted to the glucose. That process is called glycogenolysis. Or sometimes it may be the neoglucogenesis. So glucose is liberated from your produced from your amino acids and the fats, and there will be more and more proteolysis. So the protein loss will be there, and there will be more lipolysis. So there will be free fatty acid production and the ketone bodies production. So these are all will lead to hyperglycemia, protein loss, and also the ketosis. So this is all because of your counter-regulatory hormone release and because of the increased sympathetic activity. And when you see a patient with a diabetes, already had a pre-existing insulin deficiency in chronic diabetics, and if it's a type 1 diabetes, absolute deficiency. In type 2 diabetes, a relative deficiency, because even though there is hyperinsulinemia because of more and more insulin resistance, so obviously there will be the pre-existing insulin deficiency. In the same way, insulin resistance is very high in our Indian population because of abdominal adiposity. So these are the two important reasons to cause more and more hyperglycemia and ketosis and etc. And perioperative starvation on the other hand. So these people will be on only liquid diet for about 2 days or 3 days or 4 days or 5 days. And again, the fasting will cause more and more ketosis. So these are the reasons. I think this is the best slide of our today's talk, one of the best. So the surgery will cause a stressful condition, stress because it produces sympathetic activity and the counter-regulatory hormones, and then how they develop the ketosis, how they develop the hyperglycemia, why they develop the protein loss. I discussed about these things. These are all the metabolic responses to the surgery and the effects of the diabetes. What about the anesthesia? See, surgery induces a stress response resulting in an outpouring of the cortisol, growth hormone, catecholamines, and to a variable extent, glucagon. These are all the counter-regulatory hormones. We discussed about that. During the surgery, there will be the increased counter-regulatory hormones. And these counter-regulatory hormones increase the hepatic glucose production. For example, glucagon, very potent hepatic glucose production will be there with the glucagon release. And they antagonize the peripheral effects of the insulin on the tissue glucose uptake. So these are all counter-regulatory hormones are antagonists to the insulin. General anesthesia increases the cortisol levels. It's a counter-regulatory hormone. While spinal and epidural anesthesia has no effect on the cortisol. So that is the reason the best anesthesia in the diabetes is always not the general, either the spinal or the epidural, if needed, if possible. Spinal and epidural anesthesia causes the plasma catecholamine levels to the fall. So they also have a benefit to fall. That is the reason there will be the hypotension following the spinal anesthesia. But there is usually only the minimal change in the blood glucose levels. Again, the blood glucose levels will go up with the general anesthesia because of the more and more stressful conditions. Whereas during the spinal and the epidural anesthesias, the blood pressure will fall down, the blood sugars will fall down, and there won't be any counter-regulatory hormone release. That is the advantage of the spinal and epidural anesthesia in this population. Suppose if the patient had a neuropathy, and you know that neuropathy is of three types: sensory neuropathy, motor neuropathy, and autonomic neuropathy. Autonomic neuropathy causes the delayed gastric emptying, so that the stomach may still contain the food or the liquid after 4 to 6 hours fast prior to the anesthesia. So that is the reason all the diabetics should be admitted at least 1 to 2 days prior to the surgery, and they should be allowed only the liquid diet. So that is the reason we can avoid the vomitings during the intraoperative period, and we can delay the gastric emptying. Post-operative nausea and the vomiting more likely in the patients with the diabetic gastroparesis. So whenever you deal a case of the diabetes, chronic diabetes with the peripheral neuropathy, they must also had a autonomic neuropathy component. You know the autonomic neuropathy of different organs. They can cardiac autonomic neuropathy. They will have the resting tachycardia, and there will be the tachyarrhythmias, etc. In the same way, gastrointestinal autonomic neuropathy in the form of your diabetic gastroparesis, vomitings. In the same way, constipation, diarrhea, etc. Autonomic neuropathy can be associated with increased risk of cardiac arrhythmias. So that is the reason for your sudden cardiac deaths in people with autonomic neuropathy, cardiac morbidity, and the postural hypertension. So when you are dealing a long-standing diabetic, so you should also suspect the autonomic neuropathy in those individuals and be careful about these complications, especially the nausea, vomiting, tachycardia, tachyarrhythmias, and maybe the sudden cardiac deaths also. Abnormal vascular and the cardiac reflexes likely to occur during the induction of the anesthesia or the tracheal intubation of the excitation because of the autonomic neuropathy of the cardiac horizon can. Associated with the incomplete bladder emptying, post-operative retention of the urine. So as a cardiac autonomic neuropathy and gastrointestinal autonomic neuropathy we discussed. And what about the bladder autonomic neuropathy? Again, in these individuals, chronic diabetic individuals subjected for the surgery, so they must be having some incomplete bladder emptying and post-operative retention of the urine, and you have to put the catheterization also is very, very important in these cases. And again, whenever doing some procedure, again there is an entry of the organisms, and obviously post-catheter, post-Foley's catheter, so they may develop urinary tract infection, cystitis, urethritis, and then the ascending infections, etc. So all the diabetics should take a very, very, very important precautions, and all the senior sisters should be allowed to deal a case of the diabetic individuals. If you allow the junior sisters, if they don't know all these complications, and definitely they are the instrumentals to introduce the infection in these diabetic individuals. So any procedure in a diabetic individual is a potential source for the entry of the organisms into the body. Whether it's a simple intracath or your simple Foley's catheter, these two, all people, they think that they are very small things. We doctors, we need not do these two things, and the sisters or the ayahs or the ward boys will do that. Definitely, they create the problems after some time. Maybe after the 2 days or the 3 days, they develop the fever, and then the physician has to be called. Then they advise the cultures, they advise the procalcitonin levels, they advise the CRP levels, they advise everything, including the ultrasound abdomen, chest X-ray, CT abdomen, CT chest, etc. The price for these investigations will be to the tune of about 10,000 to 15,000, and you have to pay at least 5 to 10,000 to the physician charges for all these visits. And finally, the bill will be much more than what you get from that surgery. You may get maybe 5,000 or 10,000 or 20,000, 30,000, but you have to spend nearly 40 to 50,000 unnecessarily because of the poor intracat and the poor catheterization procedures given to your junior staff who are not at all having any awareness about this infection entry into the diabetic individuals. So you please think that every diabetic is a very, very important potential candidate to get the infections, especially in the perioperative, intraoperative, and postoperative periods. And patients with the peripheral neuropathy have the reduced pain sensation in the feet and may not experience discomfort from developing the pressure points and sores during the postoperative period of the reduced limb movement. This is also very common. So you tell to the patient that don't move after the surgery. You stay in the same position for about 3 hours or 4 hours. And we are really busy in our OPs, and you will be in the same position for hours together till your post-operative visit to the room or to the ward or the ICU. So you might have performed the surgery at about the 10 a.m. or the 11 a.m. or the 12 noon, and you will be in the same position till you go for the evening rounds or the night rounds at about 9 p.m. or the 10 p.m. or the 11 p.m. So he developed the blood source. He developed the pressure source. Again, this is a very, very big hangama produced by our people not moving the patient very often post-operatively. So this is also very important. So the position change is a very, very important to prevent the bed sores in these individuals, especially the chronic diabetics. You have to take very, very careful precautions, all these things. They look very simple, but they spend a lot of the money and also they stay in the hospital for the longer period. Subsequent skin necrosis and ulceration may allow the bacterial entry with a consequent cellulitis or osteomyelitis. Cellulitis we can treat with your simple ampicillin or amoxiclav, etc. But whatever the osteomyelitis, you need vancomycin, you need meropenem, you mean tigecycline, etc. Because osteomyelitis is a very, very big problem. They develop the sinus formation and the pus oozing out, etc., etc. And after 6 months or the 1 year, 2 years after the surgery, whenever he reaches to a new doctor where the surgery was undertaken, immediately, who is your surgeon, etc. And they give a bad signals to us also. So please take care of all the diabetics, especially these things. So your entry of the organisms in these parameters are very, very important. And cleanliness of the patient is very important. What about the vascular disease? As you know, the diabetes is a big vascular problem. So knowingly or unknowingly, most of our diabetics will have a peripheral vascular disease or an asymptomatic ischemic heart disease or an asymptomatic cerebrovascular disease. So the patients with the diabetes undergoing surgery for CAD and PAD often have widespread disease in other vascular beds as well. Dehydration due to the perioperative hyperglycemia may result in the myocardial infarction, CVA, or the peripheral artery obstruction in patients who are asymptomatic prior to surgery. So don't allow the patient on fasting or only on the liquids for prolonged periods to cause dehydration. See what happens when the patient is in the dehydration, the viscosity of the blood will be increased. Once there is an increased viscosity of the blood will be very thick and there are high chances of getting the thrombosis. So as a diabetic itself is a big vascular disease, so in uncontrolled diabetic individuals, if you allow the dehydration for a prolonged period, the blood viscosity will increase and this viscosity will cause a lot of the problems and also it increases the blood pressure also. Nephropathy, yes, patients with the diabetes and impaired renal function may not be able to quickly excrete a sodium or the water load. And they have to respect the electrolytes, sodium and potassium, chloride, etc. Radiological procedures involving the IV administration of the radiographic contrast material can precipitate the acute renal failure, provided if the patient is on the metformin. So that is the reason all the diabetics, when you are subjecting for the radiology department, interventional radiology, contrast studies, so please respect the output, input, and the creatinine levels. And better to stop the metformin when the fellow is on things. Patients undergoing such investigation should be adequately hydrated with IV fluids and should be observed for declining the urine output. NSAID should be avoided in the post-operative patients. So all the diabetic individuals. So definitely, preferably very, very few NSAIDs. The best NSAID is the paracetamol, and the next best is the tramadol. So 66-year-old male with type 2 diabetes of 12 years duration comes to you for pre-operative control for hernia surgery. His blood reports: fasting 188, postprandial 232, A1C 9.8. He is on top glycoside 80 mg BD and metformin 1000 mg BD. So what is your working diagnosis? Okay, type 2 diabetes, uncontrolled because of the A1C nearly 10%. Fasting is more, PP is more. Age, what respect the age also. So 66 years. What is the duration of the diabetes? That also we should respect, 12 years. So 12 years is a very big period of the diabetes, especially in uncontrolled diabetes. The age is 66 years and he is subjected for the hernia surgery. So what is your working diagnosis here? Type 2 diabetes of long duration with high HbA1c. So in a single word, uncontrolled type 2 diabetes of longer duration. So is he fit for surgery? No. See, is he fit for an emergency surgery? Yes. Emergency surgery? Yes. You have to protect him for the death. So emergency surgeries is fit. All the diabetics are fit for emergency surgeries. You have to start giving the normal saline, you start giving the regular insulin, so and act accordingly. But elective surgery is totally unfit. So you have to make him euglycemia before subjecting for the elective surgeries. So what to do? So how to control HbA1c to 6.5, how to reach your HbA1c of 6.5, fasting around 100, PP around 200. Is a very good optimum medical management. So glycoside 80 mg, so usually we use OD, but he is taking BD. Usually we go metformin 500 mg BD, he is taking the 1000 mg BD. So you don't get much benefit if you increase the glycoside TID or the metformin TID, 1000 mg. So you have the two options: continue the same OHA and introduce the insulin therapy. Okay, or second option. So no insulin because it is only elective surgery, and start other add other OHS also. And the third option, stop OHS and introduce the insulin. So you have the three options here. One option is continue the same OHA, add other OHS like your gliptins or SGLT2 inhibitors or oglibos, etc. And second option, continue the same OHS and add insulin also. Maybe your mixed add, maybe morning of 20 units, night of 10 units with the same OHS. And the third one, stop OHA and initiate the insulin on your basal bolus therapy or an intensive insulin management. So like three times regular insulin and 1 time basal insulin. So it depends on your time. Suppose he wants to get it operation before Amavasya, Deepavali Amavasya, or the before Pongal, etc. So you have the very few period, few days in your hand, maybe 1 month or 15 days or 20 days. It is very difficult to reach your HbA1c of 6.5 with your OHS in a span of 1 to 2 months. Suppose if the days are very low, then you trust the most potent anti-hypoglycemic agent is insulin. So then I ask him a leading question. So when you want to get operated? So can you wait for about 3 months or the 4 months or the 5 months? Or do you want to get it operated within the 10 days or the 15 days or 20 days? If he said earlier the better, then change over to the insulin, stop OHS. Suppose he gives time, maybe 2 months or the 3 months, then you can add two options. One, you can add OHS, other OHS like your sitagliptin or the linagliptin. Sitagliptin may be 100 mg or linagliptin may be 5 mg. And then your dapagliflozin or empagliflozin. Dapa may be 10 mg, empagliflozin start with 10 mg and you can update it to the 25 mg. And ask him to come at least once in 10 days or once in 15 days. And then see how is the fasting, how is the postprandial, and then adjust the doses accordingly, and then make him fit in another 2 months or the 3 months. So this is the very important. Am I clear? Okay. So what will you do to bring his blood glucose so that he can undergo the surgery at the earliest? So at the earliest means only one option. Okay. If you take your own time, You have the three options. So this is another case. 64-year-old undergoing treatment for type 2 diabetes for the past 20 years. So here 20 years industry. He has recently undergone a CAG, which has revealed PVD. So CAG done and diagnosed the triple vessel disease. So what is the options for your triple vessel disease? Obviously, in all the diabetic individuals, it's a bypass. Okay. Suppose if the patient is 84-year-old, had the triple vessel disease, is affordable. You have the option of PTC also. So there is no how many maximum stents one has introduced so far. Have you any idea? A person was undergone PTCA. Okay, how many stents you can put it in a patient in the history, Guinness Book of Record. Undergoing treatment for the type 2 diabetes for the past 20 years. He has recently undergone the CAG to diagnose as the triple vessel disease. Advised CABG, as you said. His blood pressure is 130/88. Very happy. X-ray test is within normal limits. Good. There is no pulmonary edema. There is no cardiomegaly. There is no pneumonia. There is no tuberculosis. There is no pulmonary hypertension. So there are no fungal balls. So there are all the things we have to see in an X-ray in a diabetic individual. So you are not there. ECG shows extensive interval ischemia. So that is the reason CAG and the triple vessel disease. Fasting 156, not happy. PPG 228 and A1C 8.2%. His blood urea, creatinine, electrolytes are within the normal limits in spite of 20 years of the diabetic life. 64 years. Current medications, glibenclamide 10 mg, that is our old book drug, Dianil, metformin 1000 mg a day, acarbose 50 milligrams TDS, so before breakfast, before lunch, before dinner, aspirin 150 milligrams per day, atorvastatin 20 milligrams per day, and telmisartan 40 milligrams per day. So he is on ARB, he is on platelet inhibitor drugs, they are on the statins, he is on OHA. OHA, 3 OHAs is getting sulfonylureas, metformin, and AIG, alpha glucosidase inhibitors. Okay, AGA. Okay. So now is he fit for surgery? Is he fit for surgery? No. So how to make him fit? Because you have to plan for the CABG. It's a major surgery. He has to admit it for 2 to 3 days prior to the surgery. And then post-operatively he has to stay in the hospital for about 5 to 10 days, maybe 15 days or maybe 1 month. So sugar control must be absolutely pakka. So in this case, my answer is, unlike your hernia surgery, I have only one option here. No OHS. Only insulin. So that depends on the surgery you are entertaining. And so here only the insulin. So again, the intensive insulin therapy. 4 shots a day. Basal bolus therapy. So start. So how much insulin you give him? So what is the amount of the insulin one should give according to the weight? 0.5 units to 1 unit per kg body weight per day. Per day. Suppose if you want to give 0.5 units in a 90 kgs, so that comes under 45 units per day. If you go up to the 1 unit, it will be 90 units per day. Some people, they may need 1.5 units also. So that will goes up to 135 units, etc. So here my question is, so 90 kgs, you are saying that 0.5 to 1 unit. How much insulin you use in this patient? With this background, 64-year-old, 20 years of the diabetic life, etc. But this patient with the 20 years diabetic life, so definitely must have very high insulin resistance and also very poor insulin sensitivity. So here your range is 0.5 to 1. So it is not 0.5 in this patient, nearly 1. So if you want to give 1 unit, how much units you have to give? 90. Now divide. Preoperative evolution of a patient with diabetes. So history is very important. Assess the symptoms of neurology, cardiac, retinal, renal, and PVD. This is very important. So history taking in a perioperative period is very, very important. Family history of diabetes, nutritional status, eating pattern, weight history, previous or current infection, use of alcohol, tobacco, endocrine disorders. So all the diabetes means we should ask about the thyroid also. So hypo and hyperthyroidism are very common companion endocrine disorder in all the diabetic individuals. History of acute hypoglycemia. Some people know the history of hypoglycemia is very high. So this hypoglycemia of the two types, neuroendocrine and adrenergic. So if the patient is having adrenergic hypoglycemia, okay, we will be very happy because he will complaining of the palpitations, perspirations, hypersweating, and he wants to eat something, and he corrects the hypoglycemia by himself. But when you take a history of hypoglycemia, it is a neuroglucopenic hypoglycemia, so that will be very dangerous. That means he develops the hypoglycemia without knowing that he is in hypoglycemia. So sudden fall, sudden hypoglycemia with sometimes with the convulsions, with the froth in the mouth, and sometimes he has to be admitted in the hospital for the correction of the hypoglycemia. So that type of issue is very, very dangerous. So unless you ask, so they don't reveal it. Again, the history of the diabetic ketoacidosis. So some people, the type 1 diabetes, when you are going to operate, so with the past history of the DKA, so very high likely he is going to get the DKA and post-operative or intraoperatively also, even though the sugars are near normal. So because he has a tendency to develop the DKA within fast, so within no time. So whenever a blood sugar reaches 250 or 300, so they develops the DKA. So that is also very important. So past history of the DKA, past history of hypoglycemia, past history of hypo and hyperthyroidism, and about the alcohol usage, and about the tobacco, and about the weight. These are all very, very important. Type and duration of the diabetes, current treatment regimens, along with the diet and results of the glucose monitoring. So this is also very important. Follow-up is also very important. And what about the physical examination? So all the patients, as usual, your pulse, your BP, your feet examination, insulin, sites of the whether there is any infection is there or not, thyroid palpation. So tender thyroid palpation. So that means tender means it may be Hashimoto's thyroiditis, painless nodules, some goiters, maybe toxic goiters. So they are very important. Unless you touch the thyroid and you palpate the thyroid, you may miss some things. So cardiac examination, your resting tachycardia, that is cardiac autonomic neuropathy, orthostatic hypotension is a very dangerous. Stress test or angiography as indicated. Some people know when they are subjected for the major surgeries, so they immediately they get the CAG also. CAG also part and parcel of any major surgeries. Airway, neurologic and abdominal examinations. And baseline, your fasting, your BP, your HbA1c, your metabolic profile, all the reasonable investigations, you should get it. So the patients posted for the elective surgery should have a reasonable perioperative glycemic control. So what is that reasonable? So blood sugar levels between 80 to 180. Non-emergency procedure should not be carried out if the patient has an evidence of hyperglycemic crisis or if the blood sugars are more than 400 or 500. If glycemic control is unsatisfactory, so better to admit the patient 2 to 3 days prior to the elective surgery so as to stabilize the blood glucose levels with your intensive insulin therapy. So a minor surgery, present treatment, diet alone, diabetes control is well controlled. So change of any treatment. So as the patient is a diabetic, it's a minor surgery. So no change of, if indicated, if the patient is able to eat and drink normally. So it's a minor surgery. Present treatment and OAD, minor surgery means some dental procedure, some cataract surgeries, etc. are well controlled, diabetes control. So no change indicated if the patient can eat and drink normally. So as long as the patient is not on fasting for prolonged hours, so you need not change to the insulin. So if the patient is taking the food and taking the liquids regularly, so let them continue the OAD, provided if the control is very good, if the surgery is a minor. What about the major surgeries? So the patient is taking the OADs, sugar is well controlled, and avoid the long-acting OHS, like your glibenclamide, or your glimepiride, or your metformin, etc. For monitor the sugars perioperatively and supplement the insulin if needed. The result of the OAD when the oral diet is resumed. So restart the OAD once the patient takes the food as usual. So again, my point here is all the major surgeries, present treatment is an OAD, diabetes control is well controlled, change of the treatment is yes. Because it's a major surgery, even though the sugar is very well controlled at the OAD, so better to change over to the insulin. And after 7 days or the 10 days, again you go back to the same OADs, because that OAD, the control is very good. So my gut feeling is, don't use the OADs, even though the control is very good, if the surgery is a major surgery. Am I clear? Then the any surgery OAD is uncontrolled, so obviously you have to need insulin therapy. Any surgery OAD, well, not under control, so definitely the option is you have to go for the insulin therapy. So preoperative adjustment of the anti-diabetic agents. So secretagogues. On the day before the surgery, if the patient is on glimepiride, your Emeril, etc., day before the surgery, take day. So secretagogues means your glimepiride, etc. Day before the surgery you take. Day of the surgery, if the posted in the morning, hold the morning dose. Day of the surgery posted in the afternoon, hold both the sides. It's a very complicated slide. So don't bother about these slides. Whenever the fellow is on the OHS, and the concept is when the posted for the surgery, so better to stop the OHS and go to the insulin therapy only. So this is the insulins. Suppose the patient is already on the insulin therapy. So what to do? So again, on the day of the surgery, usually the diabetic means posted on the first case or the second case, priority list, topmost list. Suppose the surgeon is going to operate for 5 or 6 cases a day. So again, the diabetes all on the top list. So again, the insulin, morning dose insulin, better to avoid it. And intraoperatively, the anesthetist has to see the blood sugars. And if the blood sugars are very high, and start insulin. Perioperative management, blood glucose to maintain below the 180 perioperatively. And my suggestion is below 140 or around 150. Even 180 is also very high, because that invites a lot of infections. So if you control the blood sugars if you keep the blood sugars between 140 and 150 and around 140, that would be very fine. For patients not on insulin perioperatively and undergoing the minor procedures, frequent monitoring of the blood glucose with the addition of the correction bolus of subcutaneous rapid acting insulin is usually sufficient to correct the hyperglycemia. Patients already on insulin and those undergoing the major procedures are best treated with IV insulin infusion. So now we have all the insulin syringes are there. So we'll get the 50 units of the regular insulin and 50 ml of the normal saline. So 1 ml is equal to 1 unit. So according to the blood sugars, we'll add it. Suppose if the blood sugar is 300, we start with the 3 units per hour. If the blood sugar is 400 plus, start with 4 units per hour. If the blood sugar is 200, start with 2 units per hour. If the blood sugar is 100, don't give it. If it is 150, maybe start at 1.5 units or the 2 units. It depends on the insulin resistance again, obese, etc. So this is hard and fast rule. Sometimes even at the 200, I advise 4 units per hour. So double the dose. Because the patient is obese, a chronic duration and insulin resistance is very high and uptrend. So anyhow, when the patient is on the insulin syringe and ask the sister to get the blood sugar every hourly. And every hourly will get the blood sugar, and accordingly you can adjust the doses very effectively. So the patient will not go into either hyperglycemia or hypoglycemia very fast. So that is the advantage of using the insulin pumps, etc. Even though you are not having the insulin syringe pumps, even you have the microtip IV sets. Okay, so that microtip IV sets, each 1 ml is equal to about 40 drops or 50 drops or 20 drops. So according to the drops also, we can ask the sister to monitor the blood sugars very effectively. So this is very important. But don't use the subcutaneous insulin in a dehydrated patient. So once the patient is in the dehydration, if you give the subcutaneous insulin, the absorption will be very poor. So even though you are giving the insulin, the blood sugars will go up. And suddenly after giving 10 units or 15 units, suddenly all the accumulated insulin will act very fast. Then the patient will get hypoglycemia. So that is that problem will be there. So these are all the problems you learn by getting more and more practice. So don't bother or don't fear about the insulin therapy. Insulin therapy is one of the easiest ways of treating. Just weight of the patient, 0.5 units to 1 unit per kg per day and divide accordingly. Suppose you are giving 3 shots a day. For example, you are not giving the basal insulin. You are giving the 30/70 at the night time. Regular morning, regular afternoon, and before the dinner, you are giving 30/70. Okay. So the 30/70 means 30 is your regular insulin, which takes care of your dinner, and 70 is the long-acting insulin, takes care of your fasting hyperglycemia. In that way, give only 3 shots. Am I clear? So then that third shot will be more because you are controlling both the pre-dinner breakfast and also, yes, post-dinner hyperglycemia and also the fasting hyperglycemia. So that's only a common sense. Okay. So in that way, suppose the patient requires the 90 units. So then you divide it, 3 groups. So I give nearly 40 units at the before the dinner and remaining the 50 units, maybe 20 units before the breakfast and 30 units before the lunch. Finish. Okay. Suppose you are giving 30/70 2 times a day. Before the breakfast 1 shot, before the dinner 1 shot. He requires 70 units a day. For example, he requires 70 units a day. So give more units in the morning dose because that has to be catered both the breakfast and the lunch. Because you are giving only 2 shots, no? 30/70 2 shots you are giving a day. So morning shot has to take care of breakfast hyperglycemia and also lunch hyperglycemia. And the night time you are giving 30/70, that will take care of the dinner hyperglycemia and the fasting hyperglycemia. So in that way, 70 units, you can make it as 40 morning and 30 night. Am I clear? So this is only a common sense and understanding about your food and the hyperglycemia. And if you start writing insulin in your own patients, then you will be the master. If a patient is not on insulin pre-operative undergoing, so dosing of the correction, you treat hyperglycemia. Sir, what the chart is what the chart saying? 100 to 150. How much insulin? 0. So 150 to 200. How much insulin? 2 units or 4 units. 200 to 250. How much insulin? Maybe 4 units or 5 units or 6 units. The chart. So sister follows that chart. So that means sister follows hypoglycemia or euglycemia or hyperglycemia. Hyperglycemia. So when the patient gets hyperglycemia, giving insulin. When the patient is in normoglycemia, not giving insulin. So my concept is, why should you invite hyperglycemia? Reactive. You should not be a reactive. So in following the sliding scale means you are reacting that reactive approach. You are reacting to the hyperglycemia. What I mean to say is you should be proactive. So you should see not to have the hyperglycemia at that time. Insulin and glucose infusions, if used to be continued until the oral feeding comes, that is very important. Higher dose of insulin may be needed in the presence of immobility, infection, or steroid therapy. This is very important. So some people on rheumatoid arthritis and taking the steroid regular basis, Quizalone 10 mg, 20 mg, systemic sclerosis, SLE. So we need more insulin in those individuals. So infusion of the 1 unit, maybe 1.5 units or 2 units also. Repeated monitoring of the urine output, very important. Fluid balance, urea, creatinine, electrolytes is also advised. And transfer from ICU care, the preoperative insulin regimen can be restarted. Maintain the overlap of 1 to 2 hours between initiation of the SC injection and cessation of the IV insulin. Non-insulin therapies can be restarted once the patient is medically stable and eating regularly.